Hi, everyone, and welcome back to Wellness Wednesday, where experts share insights on topics that are important to pancreatic cancer patients, survivors, and caretakers. I'm Angela Horn with Rolf Pancreatic Cancer Foundation, and I'll be co-moderating this evening's session with Savina Chacheva and our partners at Cancer Wellness Center. Today, we're thrilled to have Dr. Allison DePersia with us. Dr. DePersia is a medical oncologist specializing in clinical cancer genetics at Endeavor Health. She'll be sharing more insights on a topic that isn't discussed enough: pancreatic cancer and melanoma. For those of you joining us through Cancer Wellness Center, I'd like to tell you a little bit about Rolf Pancreatic Cancer Foundation. We're a local Chicago organization deeply connected to top pancreatic cancer hospitals and researchers in the Midwest and beyond. This year, Rolf Foundation is celebrating 25 years of providing personalized and tailored support to patients, survivors, and families in crisis. We connect families with medical experts, personalized resources, and education. We raise awareness about risks and symptoms and fund early detection research. Our hands-on approach, or as we like to say, boots on the ground and hands on the back, ensures no one has to face this journey alone. Our community has always been the heart of Rolf Foundation. In June, we hosted our 14th annual Dash for Detection and raised nearly $240,000 for early detection research. A huge thank you to everyone who came out and supported us. We have more exciting events coming up this year as we celebrate our 25th anniversary. So grab your calendars and save these dates. On September 9th, we're back on the greens for the second annual Drive for Research at Skokie Country Club in partnership with the Israel Cancer Research Fund. There are only a couple foursomes left for that event, so don't miss out. Then get ready to celebrate 25 years of progress at our Fall Gala on November 14th at Venue West in Chicago. We will soon share more details about these events, our Young Professionals Board events, and our Pancreatic Cancer Awareness Month activities. You can learn more at rolffoundation.org and connect with us through our social channels. We'll also put our links in the chat for more information and easy access. Now, I'd like to welcome my partner today, Savina Chacheva from Cancer Wellness Center. Welcome, Savina.
Thank you so much, Angela, and we're so grateful for our continued partnership with Rolf. Good evening, everyone. My name is Savina Chacheva. I'm the Program Director at the Cancer Wellness Center, and I'm so glad you could all join us tonight. For those of you who are joining for the first time, I would like to share a little bit more about the center. The center was founded in 1989 as a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, health and nutrition programs serve over 1,800 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and cope. Our services, which are both virtual and in person, include education programs like the one today that are aimed to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, mindfulness, and more that provide a holistic approach to healthy living. And support services, including counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat. Now, I would like to turn it back over to Angela, who will introduce our presenter this evening.
Thank you, Savina. Now, a few housekeeping items. Don't forget, you can ask questions throughout the session in the comments section below. We'll be saving all questions until the end to make sure we're able to get everyone. If you prefer to submit questions anonymously, you can absolutely email us at info@rolffoundation.org. We're so grateful to have Dr. Allison DePersia with us tonight. Dr. DePersia is a medical oncologist specializing in clinical cancer genetics at Endeavor Health's Mark R. Neiman Center for Personalized Medicine. She is a member of the high-risk breast team at Endeavor and has expertise in hereditary cancer syndromes and cancer risk and screening. Dr. DePersia is board certified in medical oncology and internal medicine. She earned her medical degree from New York University School of Medicine and completed her residency and fellowship at the University of Chicago Hospitals. Welcome, Dr. DePersia.
Good evening, everyone, and thank you for that introduction. I'm happy to be with you this evening to talk about this important topic. As was introduced, I'm a physician. My background is in medical oncology, and I focus in genetics. I run a high-risk clinic where I do genetic testing, risk assessment, and high-risk screening and prevention for individuals who are at increased risk of cancer, either due to an inherited mutation or strong family history. So I'm going to go through a slide deck today, review important information around hereditary cancer, specifically around melanoma and pancreatic cancer, and then we'll answer any questions at the end. So if y'all, the team's assisting me with slides, so if you guys can go ahead and put up my slides, then we can get started. Great. Next slide, please. So the goals for this evening, we're going to talk about key insights on hereditary cancer syndromes, some basics around genetics and inherited risk, how genetics specifically affect risk for pancreatic cancer, as well as risk of melanoma, and then discuss a few genes that are specifically linked to inherited risk of pancreatic cancer and melanoma, as well as some other cancers, and then discuss recommended screenings for individuals who are at increased risk due to these inherited mutations and pancreatic cancer risk in general. Next slide, please. So just helpful to take a step back and talk a little bit about the basics of cancer incidence and cancer risk. So 40% of individuals will develop cancer in their lifetime. Most cancers are sporadic, so you don't need to have a family history or an inherited mutation to be at risk of cancer. That's why all people do some level of cancer screening. We know cancer is more common as we get older, and so most cancer screening is recommended based on current age as well as risk factors. And then many factors affect cancer risk. Next slide, please. So just briefly, when we think about risk factors for cancer, so like I said, you don't need a specific risk factor to develop cancer, which is why it's really important that we all do age-appropriate population screening, but there are specific aspects of our personal and family history that will inform our risk. So there's environmental exposures, occupational exposures, for example, lifestyle such as smoking, increased alcohol consumption, BMI, then there's genetics. So we think about specific inherited genetic mutations, which we'll talk a lot more about in a little while, as well as just our general family cancer history. And then sometimes our personal medical history can inform our risk. And so specifically in the setting of pancreatic cancer, for example, a personal history of something like chronic pancreatitis would increase cancer risk as well. Next slide. So when we're thinking about cancer and risk, so like I said, the majority of cancer is sporadic, but some of it is due to inherited mutations. Roughly 5 to 10% of cancers are thought to be related to an inherited change in a gene or mutation. And this is when we say that someone has a hereditary cancer syndrome. So having a hereditary cancer syndrome is not a diagnosis of cancer. It's not 100% risk, but it is an increased risk of cancer where we specialize someone's screening and prevention. So that's the blue part of the pie in this little image. Next slide. Some people have what we call familial risk. So familial risk could be due to shared small genetic changes that are influencing risk, as well as lifestyle or exposure history that we might share with our family. So this is where we have a family history of cancer, maybe don't have a specific inherited mutation, but still have an increased risk due to that family history. That's the green slice of the pie. And then really important to understand that the gray is really the rest, where we think most cancer is in fact sporadic, and we all have that risk. And that's why we all do screening and symptom awareness and follow up with our doctors. Next slide. Okay, so now we're going to really focus in on hereditary cancer syndromes. Next slide. Okay, so just back to our basic genetics. Some of us think about this more regularly due to professions or interest, and some of us maybe haven't really looked at a picture like this since high school. But just to remind us that we have our DNA is present in every cell. It helps direct the cell to carry out certain functions. Our DNA is made into proteins, which help the cell carry out certain functions. And so essentially certain proteins help protect us from developing cancer. So when we're thinking about inherited risk, we're talking about a change in that DNA. Next slide. Okay, so our DNA is divided in, so our DNA, like I said, is the manual. It instructs the cell how to make proteins that control cell functions such as growth and replication and play a role in essentially protecting our cells from developing into a cancer cell. And then I think the next part of this slide, if you click again, it may pop up. Yeah, thank you. So our DNA is divided into genes, which are sort of like chapters, so tell our cell how to carry out specific functions. So when we think about inherited cancer syndromes, we're talking about a specific gene, a specific part of our DNA that has a mutation and isn't doing its job as well as we would like. Next slide. Great. So it's important for people to understand that we all have 2 copies of every gene in every cell in our body. So in this picture, you have a mom and a dad. Each of them have 2 copies of a gene, and then they're each going to pass on 1 copy to each of their children. So I think there can be sometimes misunderstandings or just confusing language used around inherited cancer syndrome. So sometimes someone might say, I have the BRCA2 gene, or I have the CDKN2A gene. The bottom line is that we all have 2 copies of these genes as well as every other gene. And when we're talking about having an inherited risk or a genetic mutation, what we're saying is one of our 2 copies of these genes is not spelled correctly. And so when it's not spelled correctly, that's a mutation. And then one of the 2 copies of the gene isn't able to do its job as well as we'd like. If we're talking about a gene that's playing a role in protecting us from cancer, then we're not as protected from cancer as ideally we would be if both genes were working properly. Next slide. Okay, so like I had said, the way I think about a genetic mutation is just that our DNA is essentially a letter code. So each chapter or gene is made up of sentences, just sort of the same way a chapter in a book would be. And a mutation is a change in the spelling of that gene so that it's not doing its job properly. And having a mutation, like I said earlier, is not cancer diagnosis. It's not 100% risk. Certainly for someone who has a personal history of cancer and is found to have a mutation linked to that cancer, we would say this mutation is part of the reason that you developed that cancer. But for someone who is healthy with no cancer history, we're not telling them that they will definitely develop cancer because of an inherited mutation, but we're telling them that they have specific elevated risk of some types of cancer, and then we're able to take action based on knowing that information to help screen them better or decrease their risk of developing that cancer. So that idea of an elevated risk, but not 100%, is what we call the penetrance of the gene, the level of cancer risk. Next slide. And this is just a helpful visual that I think also just emphasizes that point. So oftentimes when I talk about how most cancer is sporadic, patients are really surprised by that fact, and they think that you have to have a specific known risk factor or family history. But essentially, in sort of a very basic sense of how cancer develops, we have normal cells which are constantly replicating themselves. And sometimes when our cells replicate themselves, an error is made. And if those errors aren't corrected, then the cell can continue to collect errors or mistakes within its genetic material so that eventually the cells are growing out of control, not to the benefit of the greater person. And that's essentially when a tumor might develop or a cancer might develop. So if you have hereditary cancer syndrome, you're sort of starting with one of those spelling changes or mutations or errors in your DNA. There's still many more errors that have to occur as your cells replicate and copy themselves, which is why it's not a diagnosis of cancer, but sort of think about it as being one step closer to developing cancer than someone who doesn't have that risk factor. Next slide, please. Okay. And then why would you want to know if you have hereditary cancer syndrome? Certainly, it's a very personal choice if people pursue genetic testing or risk assessment. It's maybe not something that everyone wants to know, but certainly I have bias because this is my practice, and I think there's a lot of benefits to pursuing risk assessment and genetic testing. So it can give more precise cancer risk estimates. And if we understand someone's cancer risk and we know that it's significantly elevated, then there are opportunities to be proactive. I think if you click again, probably the other bullet points. So increased cancer screening is an opportunity. We'll talk about that, as well as risk reduction. So in the setting of the cancers we're really focused on today, obviously pancreatic cancer and melanoma, we're really thinking more about increased cancer screening. There's not necessarily surgical risk reduction or something like that, but certainly there are risk reduction in the form of like lifestyle modifications. So, if someone knows that they have a heightened risk of melanoma, then they might be more cautious around sun exposure, things like that, than they might have been otherwise. And then for someone who already has a cancer diagnosis and we learn that it is due to an inherited risk, there are opportunities to inform their treatments, their targeted cancer treatments now that are available based on certain inherited mutations. Essentially, the error in the cell that in the DNA that cause that person or increase the risk of developing cancer is also an error in the cell that we can take advantage of with our treatments to try to target the cancer cells and kill them while not affecting other healthy cells in the body potentially. Next slide. Okay, so just a little review on the elevated risk of pancreatic cancer, then we'll do elevated risk of melanoma, and then we'll talk about the specific genes that can link those. So when we're talking about hereditary pancreatic cancer risk today, I just wanted to point out that specifically focused on pancreatic ductal adenocarcinoma, which is 94% of pancreatic cancers are. There are other types of rare neuroendocrine tumors and things like that that we're not going to get in today. But in general, when people are talking about pancreatic cancer, this is often the type that we're talking about or thinking about. The general population lifetime risk of pancreatic cancer is somewhere around 1 to 2%. And someone is considered at high risk of developing pancreatic cancer if their lifetime risk is over 5% or roughly a 5-fold or greater increased risk compared to the general population. Someone can be at high risk of pancreatic cancer either due to hereditary inherited syndrome or a gene mutation, which is sort of the focus of our discussion today, or there also can be familial risk where you're looking to family history, but there's not an inherited mutation. In most instances, that's defined as having at least 2 first relatives with pancreatic cancer, or sometimes it can be 3 relatives on the same side of the family in certain clusterings as well. Next slide, please. So thinking about inherited syndromes causing increased risk of pancreatic cancer, we know up to about 10% of pancreatic cancers are due to an inherited genetic mutation that increases pancreatic cancer risk. The bottom sentence on this slide is the most important. So all patients with pancreatic cancer should be offered genetic testing, and based on current guidelines, all patients with a diagnosis of pancreatic cancer are recommended to do genetic testing because about 1 in 10 will have an inherited mutation. And like I said, it could inform their treatment. It can also inform their family members' risk and management. And certainly if the family member or person who is affected with pancreatic cancer is no longer with us because they were diagnosed before this was a guidance or they had an opportunity to do genetic testing, certainly close relatives also are eligible and appropriate for genetic testing. We're more suspicious that we might find an inherited mutation in someone with pancreatic cancer if they have a younger than average diagnosis, have relatives with pancreatic cancer, or have a personal history of other cancers or clustering of certain cancers that can be seen with some of these genes. Next slide, please. Okay, so now just a little bit around basics of melanoma and risk. So roughly 7 to 15% of individuals who develop melanoma will have a family history of melanoma. Not all of those people certainly will have an inherited mutation in their family, but potentially up to 5 to 10% of diagnoses of melanoma could also be due to an inherited mutation. And just notable that one of the genes we're focusing on, CDKN2A, is thought to be responsible for up to 20 to 40% of those inherited cases of melanoma based on what's currently available in the literature as far as research. And then there's also an entity of familial melanoma where maybe there's not a clear inherited mutation in a family, but once again, there's a stronger history than we might expect by chance. And so someone might have a familial risk where they have multiple close relatives or multiple relatives on the same side of the family who've had melanoma and be considered at increased risk. Next slide. So as far as inherited cancer predisposition syndromes that link specifically pancreatic cancer and melanoma, the main ones that we think about and that we're going to be talking about today are going to be CDKN2A gene mutations that are inherited, which is associated with FAM or familial atypical multiple mole melanoma syndrome. This is felt to be the underlying genetic cause or of pancreatic cancer diagnosis in almost a 0.5% of patients. So it's a relatively rare syndrome, but certainly something that we see in our clinics and that is important to be testing for. And then BRCA2, which is one of the genes that can cause hereditary breast and ovarian cancer syndrome. And based on what's currently known, based on research, it probably is the etiology of a larger percentage of pancreatic cancer patients. So one of the main contributors to inherited genes that we're going to be finding in people who are diagnosed with pancreatic cancer. Next slide. So this slide is just to say that there are many other genes that can be linked to inherited risk of pancreatic cancer or inherited risk of melanoma, but don't necessarily link the two. Aside from BRCA1 is on this list. So on the left side of the screen, these are genes that are known to be linked to inherited risk of pancreatic cancer. BRCA1 is probably the only one that may also be linked to melanoma, but the risk is not as strong as with BRCA2 for melanoma and pancreatic cancer specifically. There's a gene called ATM. I know there was a question submitted in advance about ATM, so we can talk more about it at the Q&A if there are questions. PALB2, there's a syndrome called Lynch syndrome, Peutz-Jeghers syndrome, Li-Fraumeni syndrome, and then hereditary pancreatitis genes. And so these are hereditary syndromes that include pancreatic cancer risk and then might have other cancer risks. So that's where when we're thinking about genetic testing or evaluating a family, if we're seeing clustering of pancreatic cancer with other types of cancers in a family, then maybe we're not thinking about CDKN2A, but maybe we're thinking about something like Lynch syndrome, where we are mainly seeing colorectal and uterine cancer in addition to pancreatic cancer, for example. And on the right, there's a few genes that can be linked to inherited risk of melanoma that are not necessarily linked to pancreatic cancer risk. These genes are definitely going to be a little bit more rare, less well known to the audience, I would expect, but MITF, POT1, BAP1, and TERT. And certainly there are probably other genes out there that are linked to inherited risk of pancreatic cancer, melanoma, and those are ongoing areas of research. There are families that have strong histories that are unexplained, and we realize there are probably other genetic changes that need to be found to help identify at-risk families. Next slide, please. Okay, so we're going to talk more about CDKN2A, like I said, related to FAM syndrome. So the key characteristics of CDKN2A inherited mutations or families that have this inherited mutation are going to be multiple melanocytic nevi. So people have multiple moles or freckles, a lot of atypical moles, sort of more than the average person might. Maybe it's something that their primary care doctor or their dermatologist has pointed out in the past. They're going to have an increased risk of melanoma. The lifetime risk estimates of melanoma, you can see this is a pretty wide estimate, 28 to 76%. Either way, this is much higher than the general population and warrants specific follow-up, but I think there's more research to be done to understand exactly what the risk is, and some of this is that different people have other risk factors beyond just their mutation, so that's why we can see a wide range of risk there. Notably, the age of onset for melanoma in individuals with CDKN2A is definitely shifted to a younger age than average. So youngest diagnoses in the literature can be around the early teens is what I've seen. And then the average diagnosis is going to be probably, so with CDKN2A, somewhere around 30 to 45, whereas it's shifted closer to like 50 or later in the general population as far as age or average age of diagnosis. And then increased risk of pancreatic cancer. So once again, there's sort of a range, but the lifetime risk is thought to be greater than 15%. There's some estimates, I think, that were closer to 19%. There may be some variability here based on which specific mutation or what change within the gene a family has, because sometimes that could affect the level of risk. And the age of onset, average age is going to be shifted younger. So potentially in the 50s versus the average age in the general population would be closer to age 70. Next slide, please. And so what are the recommendations for individuals who have an inherited mutation in the CDKN2A gene with FAM syndrome? So pancreatic cancer screening is recommended to start at age 40 or 10 years younger than the youngest diagnosed relative, whichever comes first. And this is for all individuals who have a CDKN2A mutation, regardless of whether they actually have a known family history of pancreatic cancer or close relatives. So even if a family doesn't necessarily look like a CDKN2A family, where we're seeing a clustering of melanoma or pancreatic cancer, if we find this mutation in an individual, then we would say they still have this increased risk. Why we don't see the history in all families, even though, I said the melanoma risk is, potentially above 50%, so you think you would see it. Sometimes people have very small families, so it's a truncated family, or we don't know a lot about the family history. People aren't sharing that history, and so sometimes there's just limitations in what can be known. And then there's probably sometimes other genetic changes in a family that are somewhat protective, and so maybe their risk doesn't look as high as the average risk that we're seeing with CDKN2A, but we don't have really great ways to assess those other genetic factors influencing a mutation at this point. So even if there's not a family history, that pancreatic cancer screening is really important. How is screening performed? So typically screening is done on a yearly basis with something called magnetic resonance cholangiopancreatography. This is basically an MRI of the pancreas. So contrast is given, it's phased and focused on the pancreas. And then there's also an endoscopic ultrasound, which is, I tell patients, basically like a colonoscopy from above, where it's like an EGD, that when they do the endoscopy, they go all the way down to the start of the small intestine. They're basically able to look through the wall of the small intestine at the pancreas. So both of these, the goal is close visualization of the pancreas to see if there's any growth or changes that are abnormal or concerning. And basically, they're both good ways to visualize the pancreas, and they complement each other, so they can be rotated on an annual basis to be looking at the pancreas. The EUS is an invasive study, although it's certainly a low risk study. MRI obviously is just a radiology imaging study where you're in the scanner for 30 minutes to an hour. And then from a melanoma perspective, we recommend dermatology screening every 6 months. This would start as early as age 10. So in some instances, it may be that younger generations are not doing genetic testing yet in the family, but they may just start the melanoma screening, recognizing that they have a chance of having inherited the mutation, but they're not ready or age appropriate to really be pursuing the genetic testing yet to see if they inherited the CDKN2A mutation from one of their parents. Next slide. So this slide is really important and really exciting. So the goal of pancreatic cancer screening specifically is to diagnose pancreatic cancer when it's pre-symptomatic. And years ago, even when I started my own independent clinical practice, we didn't really have good, reliable pancreatic cancer screening. There were studies around MRCP and EUS, but just not a lot of data. And so often people were told you're at increased risk, but there's really not a lot we can do for you, or your insurance is going to cover these screenings and they're expensive. So we now have a lot of good data to show that pancreatic cancer imaging surveillance is very beneficial. So there was actually a publication that just came out in July. So there's a few groups that study pancreatic cancer screening. There's the PROCEED Consortium, which is something that Endeavor Health is part of. And then there's also the CAPS Consortium, which is a smaller group of institutions that's been doing screening for the longest period of time. There's not any sites in the Chicagoland area, but it's a few institutions all over the US. And what they've been able to demonstrate is that individuals who are diagnosed with pancreatic cancer based on screening are usually asymptomatic and much more likely to be early stage. So it's sort of a flip, whereas screen-based pancreatic cancer diagnoses, about 70% in this most recent publication from the CAPS group, are either stage 1 or 2, versus when they compared to a historical cohort from the SEER database of just general people being diagnosed with pancreatic cancer, so presumably based on symptoms, oftentimes unexplained weight loss, jaundice, significant epigastric or back pain. only 30% of these individuals were going to be stage 1 or 2, so sort of a flip there. This means that people who are diagnosed on screening are much more likely to be surgically resectable or candidates for surgery, which is going to where we have the best chance of good treatment and prolonged survival, and then also less likely to be metastatic. So in this most recent publication, when it was screen detected, it was about 1 in 4 people where they might have a distant metastases, where as in the general population, if it's symptom-based, it's more than 50% of people are going to have an image detected metastases, so at diagnosis. And then what's important is that we've now been doing the screening for, I think the CAP studies have been going on for over 10 years now, so they have follow-up data and large numbers to be able to say that they have improved 3 and 5 year survival. So for example, the median overall survival in the screen-detected pancreatic cancers was 62 months, whereas for symptom-based diagnosis, it was 8-month median survival. So that is a meaningful difference. I tell my patients that it's meaningful 3 and 5 year survival, where yes, someone might have a big surgery and they need treatment, but they have meaningful improved quality of life for many years, and certainly can be longer than 3 to 5 years, but this is just looking at what we have data-wise. We haven't been doing this long enough to say whether we have people who are cured of the disease or living for decades after, but that is certainly the hope and something that just warrants more study to be able to figure that out. Next slide, please. Okay, so the other gene we were going to talk about is the BRCA gene, which is linked to hereditary breast and ovarian cancer syndrome. Like I said, the main genes linked to hereditary breast and ovarian cancer syndrome are going to be BRCA1 and BRCA2. I tell patients that the risks are pretty similar between the two genes. They're linked to inherited risk of breast, ovarian, pancreas, prostate cancer, and melanoma, but there are some differences between the two genes as far as which risks are higher for each gene. So specifically for BRCA2 is where the risk is going to be slightly higher, specifically for pancreatic cancer or melanoma, which is why that's sort of what the gene we're focusing on today. So BRCA2, the highest risk for females is going to be the breast cancer risk. It's greater than 60% in one's lifetime. The ovarian cancer risk, I usually say around 20%, but there's a range of risk here. The pancreas cancer risk is somewhere between 5 and 10%, whereas BRCA1 risk is thought to be equal to or less than 5%. Just remembering that 5% is traditionally the cutoff we use to consider someone high risk, where we might consider screening for them. Prostate cancer risk estimates are pretty broad, but probably closer to that 60% number. And then melanoma, there's not good published lifetime risk estimates, but there definitely is an observation of an increased risk of melanoma, and more so in BRCA2 than BRCA1. Next slide, please. So just reviewing all of the screening recommendations for BRCA2 carriers, and most of this would also apply for BRCA1, but BRCA2 for breast cancer for female risk, we do annual mammogram and MRI. We start the MRI at age 25, the mammogram at age 30, and then there's also the option of risk-reducing mastectomy given that level of risk. Ovarian cancer, we don't have good screening, so we recommend risk-reducing removal of the tubes and ovaries, which is where the majority of ovarian cancers start, by age 40 to 45 for BRCA2. For BRCA1, that's shifted a little bit. It's 35 to 40 because we see slightly younger ovarian cancers and slightly higher risk. Next slide. And then the cancer risk that we're most interested today in our discussion. So for pancreas cancer screening and risk, so screening typically starts around at age 50. If there's a family history, or 10 years younger than the youngest diagnosis, should there have been a young diagnosis, then you move up that screening age. And once again, the screening, the data I shared when I was sharing CDKN2A, that comes from a group of patients who met those high-risk criteria. So it was BRCA2 and CDKN2A patients as well as others. So we know MRCP and EUS are very effective for these patients too. I think one thing that's really notable and important to point out, and something that I've been talking a lot with my patients about, is that Traditionally, the guidelines for pancreas screening for BRCA2 have said that you screen if there's a family history and a close relative. The thought being that there's some families with BRCA2 mutations where we're seeing pancreatic cancer and some where we're not. And was there something that increased the risk in those families that had the history versus those that don't? But then when we look at people being diagnosed with pancreatic cancer, BRCA2 mutations, it's a lot of the people didn't have a family history. And so based on that, there are some newer guidelines by ASGE, which is one of the societies around advanced endoscopy, who said we should consider screening for all BRCA2 carriers who are 50 and above, regardless of family history. What's difficult about this is that there's many societies who put out guidelines around screening. And so CAPS, which I mentioned, which is probably the biggest group who has the history of doing pancreatic cancer screening, and then NCCN, which is the National Comprehensive Cancer Network, which is where most of our cancer risk and screening guidelines come from, still say you need to have a family history to qualify for screening for pancreatic cancer with a BRCA2 mutation, whereas this ASG says all patients. So and there's a lot of debate among specialists in my field about what the right fit is. Like, if you don't have a family history, is your risk truly 5 to 10%, or is it only those with a family history in BRCA2 who have it? So I've been telling all patients to talk to their providers, talk to their family members about how they could be doing screening, regardless of family history, recognizing that not all insurance companies are acknowledging that ASG guideline, and they're going based on the CAPS and NCCN guidelines, which say you need a family history to be doing screening. And then, like I said, the screening outcomes, the same data that I had shared with CDK and 2A applies to this population as well, as far as it being very effective. Prostate cancer screening, we start PSAs at age 40. And then for melanoma, like I said, it's an association, but we don't have precise risk estimates. But we do recommend annual whole body skin exam, or at least a baseline exam, and then follow up with the dermatologist as they feel appropriate every 1 to 2 years, given that we can see a higher incidence of melanoma and BRCA2 carriers. And then, of course, lifestyle modification too. Next slide. Okay, so that was my last slide. I guess the only other thing I wanted to mention, which I didn't have a slide around, but is important to say, so for pancreatic cancer and for melanoma, there isn't like a surgical procedure or medication at this point that we can give patients who have a genetic increased risk to decrease their risk, but we know that there are certain lifestyle factors that certainly contribute. So, for example, smoking contributes to increased risk of many types of cancers, but we know with pancreatic cancer, there's definitely a strong link there. So smoking cessation is really important. And it's true with many cancers that are smoking linked, like lung cancer, for example, that even if you have a history and you quit, like you have some risk, but you can still benefit from having quit. And the more distant you are from it, the more your body sort of is healing from that damage that was done from the smoking. So it's never too late to quit smoking. And then alcohol consumption, we know it increased cancer risk. There's some really good data around breast cancer risk and alcohol consumption, and how there's like a dose dependency. So even moderate or appropriate drinking, what's considered like safe levels of drinking could still be increasing cancer risk. And so alcohol presumably contributes to pancreatic cancer risk as well. Certainly someone who drinks excessively or has pancreatitis or things like that, where there's damage to the pancreas, we know it's increasing pancreatic cancer risk, but also just thinking about moderating alcohol consumption in general. And then around melanoma and skin cancer, we know that thinking about our sun exposure, protecting our skin, avoiding burns. A lot of that damage is sometimes done when we're younger. We're not as wise to these things, but trying to raise awareness in younger generations as well, and use sun protection is really important. This last slide just includes where I'm located, which is the Neiman Center for Personalized Medicine at Endeavor Health. So we do hereditary cancer genetic testing. I run a high-risk cancer screening clinic, so patients who have inherited mutations or strong family histories who warrant screening, and then counseling around risk reduction, surgical referrals, or medications. Like for breast cancer, for example, we can give medications to reduce risk. And then our practice also includes general medical genetics too. So some of my colleagues are general medical geneticists who might do cancer genetic testing or other testing. And then we specifically have a high-risk pancreas clinic at Endeavor at one of the North Shore Legacy sites that's run by myself. I identify patients and refer them over, and then Dr. Melissa Hogue, who's one of our pancreas surgeons, helps run the screening clinic with a nurse practitioner colleague, where they're doing that annual imaging with MRCP, and then also incorporating EUS with one of our interventional GI doctors. And then my physical office clinic where I see patients is in Evanston, and our phone number is there as well. But that was really the basic outline of what I wanted to cover, and then I'm happy to answer questions that people have around BRCA2, CDKN2A, or other inherited genes linked to pancreas cancer risk, or basics around cancer genetics, screening, etc.
Perfect. Thank you so much, Dr. DePersia. That was excellent, excellent information. Now we are going to open up for questions. Several have come through during the talk, but if you have additional questions, please continue to ask. Again, if you don't feel comfortable doing so in the chat, you can email us at info@worldfoundation.org. Also, one final note before we get rolling. We understand that this topic is very personal, and while we want to answer everyone's questions, we unfortunately must refrain from questions targeting individual medical advice. So with that said, the first question we have here for you, Dr. DePersia, is what is the difference between using blood and saliva samples for genetic testing? Is one better than the other?
Sure, good question. So both blood and saliva are reasonable sources of DNA for genetic testing. So historically, we did blood-based testing. What you do when we do genetic testing, so if it's blood, we're essentially removing the white blood cells, removing the DNA from those cells, and then the lab is sequencing or looking at the spelling of specific parts of the DNA or the genes that we care about. So we can also take cells from our saliva, which includes blood cells and other cells, and extract the DNA from those cells too. So the quality of a genetic testing result from saliva or blood is equivalent. Historically, we used blood, and then honestly, during the pandemic, when going to a lab was a risk that patients didn't need to take, and we were practicing virtual telehealth almost entirely, that's where we really shifted to saliva, because we could ship the kits to the patient's homes. They could do a swab or spit into a test tube and then mail it off, and it's totally reliable. In rare instances, saliva has a slightly higher likelihood of failing, just because sometimes when people spit into the test tube, like the bubbles don't really count. I tell them it's like that you actually need like the liquid spit to get like enough cells and enough DNA. So sometimes it fails because they don't get enough genetic material from saliva, but if you get a result, then it's a good result. So sometimes if it's urgent testing, like a new breast cancer patient or something that's going to guide someone's therapy in the very near future, we usually prefer to do blood, just because there's a lower likelihood of it failing or not getting enough sample, but they're both totally reliable.
Right, that's good to know. I was actually curious about that too. Can you explain what a genetic variant of uncertain significance means?
Yes, yeah. So a variant of uncertain significance, or as we call it, VUS, in sort of medical abbreviation lingo. So basically, when we do genetic testing, what we're doing is I think of, like I said, our DNA as like a letter code. And we're looking at specific areas of the DNA, specific genes, where there's a correct way to spell the gene. And we're sequencing the gene to see if it's correctly spelled. Sometimes we see a misspelling in the gene, but every misspelling is not necessarily a mutation. So a misspelling in a gene that makes the gene not be able to do its function, not be able to make that protein that then carries out whatever job the cell needs to do, that's a mutation when the spelling change affects the protein. Sometimes there's a spelling change where we say this is just probably this, or this could be normal variation. So we haven't done genetic testing on every person, and we're a diverse population. So there's not just one right way to spell a gene, but as far as like the reference code or what the labs use to say how the gene should be spelled, they only have, a certain number, let's say 10 correct ways to spell the gene, but we know that doesn't reflect population diversity. So sometimes we see a change in spelling in someone, and we haven't seen it enough to say this is definitely a problem where the gene isn't going to work and it's mutation. We just don't know. It could be normal variation. And once we see it in enough people, we study it and we prove that it's normal variation, then we downgrade it to say this is benign. And we wouldn't even tell people about the spelling change because it's just a normal variation of how you spell the gene. Or in some instances, we study it enough and we say, this is actually a spelling change that is a problem. The gene isn't doing its job, making the right protein, and we call it a mutation. It's something that we tell patients, the more genes you test, the more likely you are to get a VUS, because we all have some rare changes in our genetic code that are not like exactly the same spelling as the reference code, but that doesn't mean it's a wrong spelling or a problem. And usually what we do in those instances is we tell patients we're not going to make a change based on a VUS or variant of uncertain significance. We're going to make an assessment of your cancer risk based on your family history. So if someone has a VUS in a gene that's linked to colon cancer and they have a family history of colon cancer, that does not mean this VUS is a mutation. We're going to still put the VUS aside and say, okay, you have a family history of colon cancer. Is that family history strong enough that we should be changing your screening? So we just, I always tell patients the labs are, I say we, but it's really the United States community, the labs are constantly updating the information they have in VUSs. And if they learn that it's either benign, shouldn't even have mentioned it, or yes, mutation, increased risk, we need to do something about it, then what they do is they let your ordering team know about it, and your ordering team should update you. So it's really important that wherever you had your initial genetic testing, you keep your contact info up to date with them. So if you move out of state or to a different health system, you still want to make sure they have your contact info, or you're seeing a genetics provider every few years to just check on that VUS. Because if we don't have a way to contact you, then we can't tell you if there is an upgrade and it is now considered a mutation.
Okay. I think this ties into the next question here. Speaking of family risk, if your family doesn't have a history of cancer that's known that's known now, should you still consider getting tested or save the money?
So it's a really good question. And I think you could ask a lot of different experts in my field and you might get different answers. So historically, genetic testing was done for people with very strong family cancer histories or personal histories, where we said this is more cancer than we expect by chance based on population incidence, and we're suspicious that there's something that's increasing your risk. Maybe it's genetic risk. And part of it was that when genetic testing first rolled out, it was time consuming, it was expensive, and there were limited genetics providers. So it wasn't something we could offer to every patient. And what we've learned over time is that family history is informative, and it does tell us about some families that are increased risk. But like I said, I think when I was talking about how you could have a CDKN2A mutation out of any family, pancreatic cancer, family history of pancreatic cancer, melanoma, and you sort of say, how is that with these risks being that high? Well, some of it is people didn't talk about cancer history as much in some families, or you have a really small family. So even though there's a high risk, even if it's an 80% risk, if there's only 2 people in the generations above you in that family, might not see a cancer history. So we know now that family history is not always informative, and we do find mutations in people who don't have family histories. So certainly anyone can pursue this testing. From a guidelines and insurance coverage perspective, the recommendations still are around family history and certain criteria that are met based on personal family history for insurance coverage. But there are ways to get testing with sort of capped out-of-pocket costs. We have a program at Endeavor Health that's called the Genetic Wellness Assessment and the Breast Health Assessment, that basically patients complete questionnaires around their personal and family cancer history prior to their primary care appointment or their annual screening mammogram. And based on those answers, they're told whether they might meet criteria to be recommended for genetic testing, but they're also told that even if they don't meet criteria, if they're interested in genetic testing, they certainly can, because the cost of testing can often be capped at usually around $200 to $250 if not billed through insurance. So it's certainly something anyone can pursue. I think the one thing that causes pause among experts in my field is that a lot of the cancer risk estimates for genes, so like the risk of pancreatic cancer for CDKN2A, most of the studies that looked at that gene, they looked at families who had strong histories of pancreatic cancer and got tested for CDKN2A. And so they came up with the lifetime risk estimates based on those families with strong histories. So the thing is, if you come from a family that doesn't have a strong history and we find a CDKN2A mutation in you, are those risk estimates correct? They're the best we have. So yes, we'd manage you based on that, but maybe there's something about your family that was a little bit predictive. So maybe your risk is a little bit lower, other genetic changes. So there is this idea like a polygenic risk score, for example, which looks at small genetic changes throughout our genes that maybe lay over the one inherited mutation to shift the risk a little bit. So sometimes the risk estimate is not maybe as applicable to someone who has no family history, but it's still the best we can do, and we should still screen you and treat you at increased risk, even if you don't have a family history. But just recognize that maybe your risk number is slightly different, and we'll learn that over time. And as we learn that, maybe we can differentiate screening a little bit more based on family history and other genetic factors.
Good. Next question is, I didn't know there was a connection between pancreatic cancer and melanoma. Why do you think more people don't know the connection, and is it a newer discovery?
Good question. I think genetics in general, cancer genetics is just a newer field. So the genes that I think have gotten media attention and that most people know about, BRCA1 and 2, for example, because of well-known people in the in the media who've been affected or what have you. Those genes have been studied and been available for clinical testing since they were sequenced in the mid 90s, for example. Clinical testing in its earliest fashion was in the late 90s, early 2000s, but weren't really accessible to the general population until closer to 2010, 2012. And so, and historically, when we tested, we were only testing like one or two genes at a time. So genes like CDKN2A, I can't tell you exactly when it was sequenced. It's probably been around for some time in research setting, but as far as it being clinically accessible and there being like reasonable, fast tests that are cost effective where we can test CDKN2A, that has not been the case for that long. So, and then I, don't think it's gotten the same media attention. We do these common hereditary cancer panels, and, usually those panels have around 40-ish genes, but, most people don't know the names of a lot of those genes. So, it's a pretty specialized field, pretty niche, and, but it's definitely something that's been studied for quite some time. And so the data around CDKN2A is good data.
Okay, great to know.
Yeah.
If someone has already had cancer, should they still consider getting tested?
Yes, 100%. There are a few reasons. So, we have a lot of cancer survivors who should do genetic testing because they were diagnosed with cancer when genetic testing wasn't commonplace. And just because you've had one cancer doesn't mean you're not at risk for additional cancers. And if you have a genetic mutation that links, breast cancer and pancreatic cancer, like BRCA, and you've had a breast cancer history and you've been treated for that, and you're doing other cancer surveillance, then we'd want to know if you have an increased risk of pancreatic cancer so we can screen you for that, because otherwise we wouldn't be. If you have a cancer history and you have advanced disease or recurrence or something like that, then an inherited mutation could inform your treatment. Like I said, the same genetic changes that increased one's risk of cancer sometimes make that cancer more susceptible to certain drugs because of basically the mutation within the DNA. So we can sometimes do targeted therapy or know patients are more sensitive to certain types of therapies. And then even if that's not of interest, like sometimes, everyone sort of has different preferences and goals around screening as they get into older years. And so sometimes I'll have a young patient who comes in and I'm like, your grandmother should really do the testing. They had breast cancer. And they're like, my grandmother's in her 80s and she's not looking to do more cancer screening. And I understand and I respect that. And it's not always the right fit for someone based on their life expectancy, their goals. But for that grandmother to do the testing, then if she has a mutation, then we know that all of her kids need to test, and then we know which grandkids need to test. So if it's not done for the person who has the cancer history, it's still really important for their family members. And sometimes, you want to check with your family members first and say, do you want to know about this? Do you want me to do genetic testing? Maybe not everyone wants to know, but I think even if it's not for yourself, it makes sense to pursue the genetic testing if you have a cancer history and you're recommended to do it.
Absolutely. Forgive me if this was already covered, but if someone had or has stage 4 PNET, does that kind of cancer have genetic implications related to melanoma?
So PNET is a pancreatic neuroendocrine tumor, so it wouldn't be linked to like CDKN2A or BRCA2. We're talking about pancreatic adenocarcinoma. So that's sort of a different topic. In some instances, there are instances where we do genetic testing around neuroendocrine tumors, for example, but that wouldn't fall into like this topic of CDKN2A or BRCA2, for example.
A question submitted here says, my husband passed away from pancreatic cancer. What should my adult children know? What should my adult children know about it and be aware of?
So I think the most important thing that the adult children can do is go get their own genetic testing. So presumably, if the person who's asking this question, I'm guessing that their partner did not have access to genetic testing before they passed away from their disease. And so basically we'd say there's roughly a 5 to 10% chance that that individual had an inherited mutation. And since we can't test them because they're no longer with us, we'd recommend that their close relatives, so their adult children and siblings, or potentially parents, pursue genetic testing to understand if any of them carry an inherited mutation. And if they did, then, the assumption might be that it came from their father if it's linked to pancreatic cancer, but there are ways to figure that out by testing other paternal relatives, for example, to see whether it's tracking within that side of the family. So certainly the adult children should do genetic testing. In general, I say adult children because many of their hereditary cancer syndrome don't have relevant cancer risk or screening recommendations until adulthood. So we usually prefer to test people for these types of genetic mutations once they're 18 or older, so that they're decisional adults versus assenting minors. We want them to want to have this information and make that decision for themselves, since it's not going to change their medical care until they're adults. Obviously, there are exceptions to that. As I mentioned with CDKN2A, melanoma screening would be appropriate in younger individuals in the family, but because seeing a dermatologist is a quote, pretty easy thing to do. You don't necessarily need to test the minors in the family. You can just have them start skin cancer screening, and then when they're older and they're sort of ready to make that decision and understand the other implications, then they might pursue the actual genetic testing to see if they share this CDKN2A mutation or not. And if they don't, then maybe they can stop going to the dermatologist too if their screens were all clear and there were no other concerns, until they had active concerns again.
Yeah, great. Okay, is it possible to get reoccurring melanoma after one instance? For reference, this individual is post-Whipple and 6 months cancer-free.
Mm-hmm. So, right, there's, I think sometimes like terminology around cancer can be confusing. So there's recurrent, and then there's a new primary cancer. So someone with a CDKN2A mutation, for example, who had an inherited risk of melanoma, could have a melanoma, be treated with it, worked with like a wide local excision. It's an early melanoma, and their doctors say you're treated for this, you're cured. Obviously, you're going to continue screening. There's always some small chance of recurrence or that cancer coming back, but based on the stage, it might be very low. But they still need screening because they can have a risk of a second primary melanoma. So it's like, just because you've had a melanoma doesn't mean you can't get another new melanoma in another part of your skin. And if you're at an increased genetic risk, certainly in CDKN2A individuals and families is where you might be more likely to see someone who's more than one melanoma diagnosis in their lifetime. And so also, if you have a CDKN2 mutation and you get pancreatic cancer, it doesn't mean you can't also get melanoma. You don't get one of the cancers and you're cleared. It's not as common or as likely that we see patients who've had multiple other cancers associated, but you do sometimes, right? Like you certainly see people with BRCA2 mutations who've had breast and ovarian cancer or things like that. And that's what makes us suspicious that they have that history. So you need to screen for the other cancers, even if you've had one of them.
Okay, super helpful. You suggested a dermatological screening every 6 months, but my insurance only covers one per year. Do you have any advice to get 2 screenings covered?
In most instances, what happens is these are relatively rare inherited syndromes. And oftentimes, I don't know exactly how insurance works, but there's general guidelines that insurance follows. And then they don't always know the more nuanced or specific guidelines. So in my clinical practice, if there's an imaging study or something I order for a patient that gets denied, there's usually an appeal process that I can pursue as the physician. And certainly in an instance like this, where I know there is a published expert opinion or something that I can reference to say twice a year would be appropriate, then I will often do that. Usually the appeal has to come from the provider who's providing the care. So I would assume in this instance, it would need to be like a dermatologist who was appealing to get a second whole body skin exam covered per year. If you have concerning skin lesions, I think there's a lot of reasons people see a dermatologist more than once a year. So I sometimes there might be another way to get that appointment covered for you, for example. But I run into this more, for example, like I was saying with BRCA2 pancreatic cancer risk and screening all BRCA2 carriers 50 and over, even if they don't have a family history. I have a lot of insurers that deny me, and I will appeal it. And sometimes if I tell them about this other guideline that's published, they'll overturn that appeal and they'll cover it. And sometimes they'll say, look, we're following the CAS guidelines, which are the most well-regarded guidelines. And so we recognize that the other guidelines are out there, but until there's more data behind them, we're not going to cover it. So, but I think an appeal is always worthwhile, and it's time consuming for the physician, but hopefully they are able to do that for patients.
Okay, great. The next question I think ties into that, but I just want to make sure. They have a question concerning screening. Since the specific test that was recommended is not covered by insurance, they have PALB2. All these acronyms.
PALB2. You're good.
They have that gene mutation, and what do they advise for next steps? Does that cover?
Yeah.
So
PALB2 yeah, PALB2 is associated with an inherited risk of pancreatic cancer, as well as primarily breast and ovarian cancer that we think of. The current NCCN and CAPS guidelines recommend screening for age 50 and over if there's a family history in a close relative, which would be a first or second degree relative. The ASGE guidelines that I referenced do include screening, even if there's not a family history, for BRCA1, 2, and PALB2. So there is like a reference out there that potentially an ordering provider could use to appeal the guidelines. But like I said, so I think a provider could order an MRCP. If it were denied, they could try to do a peer-to-peer, but if it doesn't work, it's not the physician's fault, or it's not that they didn't get the right info. I've referenced the guidelines and been denied, and sometimes I've referenced them and been successful. So, but it could be considered. Yeah.
Great. And I just want to be cognizant of time here. I know that we're technically over time. We just have so many questions coming in. So I am so thankful for everybody's time as we're going to continue on here for a little bit longer just because there's so much interest. We're so thankful. So next on the docket would be, what kind of doctor do you need to visit to get these screenings done? Would an internist request them for us?
It's a good question. And every clinical practice is different. So I'm really fortunate that I get to practice hereditary cancer, like genetic testing and screening for my entire practice. A lot of people, this is part of their practice. So, there are a lot of sometimes like a pancreas surgeon might also do the high-risk pancreas screening, or a breast surgeon might do the high-risk breast surgeon. My practice is sort of unique that I can cover I know all the cancer risks and do all the screening or refer out for specific needs. I tell patients that they often leave genetic testing with like a list of their risks and recommendations. Not every internist is comfortable carrying out that screening. Understandably, it's very nuanced, knowing what to do with the results, knowing the guidelines, knowing how to get the screens covered because of diagnosis codes. So I don't want to speak for any one internist. I certainly have some patients whose internists do their screening for them and they check in with me every few years. I have some patients who see me for the screening. So it just sort of depends where one's located. I tell patients, as far as what I tell them to tell their family members who aren't local and I can't see them, I say, I'd start with a genetics provider because the people who do the testing and identify the mutations are going to be the ones who are referring out to specialists. So they probably know the specialists in their area who are doing this screening so that they can find whoever that person is, whether their background's oncology or surgery or genetics, who's carrying out the screening. If the internist isn't comfortable with it, the internists also have a lot else that they're covering. So I don't expect them to be experts in rare hereditary cancer syndromes.
Understood. Where is back pain typically located with pancreatic cancer? I did CT scan and doctors found nothing wrong, but I still have gastric pain sometimes and back pain on the left side of the body. What specialist would I see for pancreatic concerns? A hepatologist?
So I don't, I think if someone has back pain that's persistent or concerning them and they haven't found a good explanation, then I think it's good to continue discussing with a doctor. A CT scan is like a very good way to evaluate the pancreas, but the type of doctor who specifically deals with the pancreas, so a hepatologist is like an internist who does GI and focuses on the liver. So someone like a pancreas surgeon, for example, might be the person who focuses on the pancreas within a practice. If someone wanted to have further evaluation or imaging, certainly in our practice for people who are at increased risk or doing screening, like I said, we have them see our pancreas surgeon. But there are a lot of causes of back pain. So I don't, by mentioning some of the symptoms that we might see in advanced pancreas cancer, I think they're also very non-specific when you talk about weight loss or gastric pain or back pain. But just if you have symptoms or concerns, you want to tell a doctor. And if you're at specific risk for cancer or something like that, you want to make sure they know that when they're evaluating you so that they're not, not thinking about those scenarios as well when they're thinking about causes.
Okay, great. How far into a person's family tree should they be looking for familial risk?
Yeah. So the guidelines talk about close relatives, which is either defined as second or third degree relatives. So first degree is your parents, your children, your siblings. Second degree would be like your grandparents. Third degree would be like your great grandparents, for example. So I think it's sometimes harder with older generations to know, just because if we think about our great grandparents and how medicine was practiced then, family history is not as reliable. Whereas like third degree relatives or maybe cousins, maybe that's more reliable because their medical history is like in contemporary medicine. So we usually go out to third degree relatives, but I often, when I'm hearing histories around like, great grandparents, great aunts and uncles, depending on what decade their care was, sometimes that's not as reliable history, but we still do usually go out to that third degree level.
Okay, great. Next question would be, you mentioned the high-risk pancreas clinic. Is that meant for people already diagnosed with pancreatic cancer or for people who have a family member with pancreatic cancer and want screening for themselves?
Our high-risk pancreas clinic is run by Dr. Hogue, who's also a pancreas surgeon. So she sees pancreas cancer patients for surgical consultation and care. But the high-risk clinic is specifically for people who are at increased risk of pancreatic cancer but don't have a personal history. So the close relatives of people who've had pancreatic cancer or people who have inherited mutations are the type of patients that we're seeing in the high-risk pancreas clinic to talk about screening and implement their screening for them.
Okay, great. And again, thank you for everybody for hanging on. We're still just going to continue on all this good data if we are good to continue. For individuals that had previous genetic testing, are there instances where updated testing may be indicated?
Definitely. I don't have a year or a specific cutoff because genetic testing has sort of just evolved naturally as far as the technology and the genes that we test for. But I certainly can say that if a family member did testing, 10, 15 years ago, then it's definitely most likely that it wasn't what we call a broad panel. So it probably didn't include all the currently known pancreas cancer risk genes, for example, and update testing would be warranted. If it were more recent testing, sometimes it's still not as broad because there's just different practice preferences. As far as if people are testing for the highest risk genes versus more moderate risk genes. So unfortunately, I have like my medical colleagues ask me this a lot, like what year, after what year should we be doing update testing? And I don't have a good cutoff, but if there's a family history and it was only BRCA1 and 2 testing, or it was very limited number of genes, it wasn't a panel, then it's very possible there's a role for update testing for newer genes that were identified linked to hereditary cancer risk. You have a visitor. Hi.
Cause a little chaos. Okay, just a few more questions here. Am I understanding correctly that the link is between adenocarcinoma and melanoma and not PNETs and melanoma?
Yeah, CDKN2A is related to pancreatic ductal adenocarcinoma and melanoma.
Okay, perfect. And is MRI better than CT scan for early detection of pancreatic abnormality?
So CT is another good way to evaluate the pancreas. The reason we don't use CT scanning for screening in general is because CTs have radiation and MRIs don't. So for individuals who have a need for recurring imaging on an annual basis or every other year, MRI is preferred because then you're not getting that radiation exposure. Usually CT is the test of choice if it's more of a diagnostic evaluation. So someone who's symptomatic or having follow-up for treatment, like a pancreatic cancer that's being treated with chemotherapy and they're looking to see disease response. Oftentimes it is a CT that we're using, but in the screening setting for most hereditary cancer syndromes, CT or MRI might be a good way to evaluate a lot of organs, but we often choose MRI because it doesn't have that radiation exposure.
Right. I think we are down to the final question here. Final question for you, Dr. Persia. What are 3 key takeaways you'd like our viewers to leave with tonight?
Every person who has pancreatic cancer should have genetic testing because it can inform their treatment, inform their family members' cancer risk, and inform their own future cancer risk. And if you have a relative who has passed away from pancreatic cancer, then you can pursue the genetic testing if we can't test them. Pancreatic cancer screening does exist because I think a lot of people don't think it exists, or they were told 5 or 10 years ago that it didn't exist. And when they were told that, it was pretty accurate in that we didn't have good data around it and maybe insurance didn't cover it. Now we have good screening with meaningful improvements in outcomes as far as improved 3 and 5 year survival. And those outcomes may in fact be even better, but there's some limitations because we just haven't been studying it for that long. And then really anyone who wants a genetic risk assessment or cancer genetic testing can do it and should have access to it. There's some people who are more suspicious based on family histories, and we think that their pre-test probability, their likelihood of finding a mutation going into testing is higher, but we certainly can find mutations sometimes in people who don't have a family history. So if people want to pursue genetic testing, they can do it. And and in that vein, that is in part because it can be done for, it's not inexpensive, but it's not the thousands of dollars that I think a lot of people think genetic testing is. In this day and age, out-of-pocket costs can be capped at $200 to $250. And if you meet criteria, then oftentimes it's covered entirely, although one's deductible can certainly play a role in that cost. But the labs are really great at working with people around cost of testing. So finances should not be a barrier for genetic testing in this day and age.
Absolutely. Couldn't agree more. Thank you so much, Dr. Allison DePersia, for such a candid and informative discussion on this important topic. And thank you to Savina and Cancer Wellness Center for partnering with us. To learn more about Cancer Wellness Center, please click the link in the chat. And I would also like to thank you all, everyone, for joining us tonight. If you're catching this on replay, be sure to write replay in the comments and ask your questions so we can get back to you. We will be announcing details for our next Wellness Wednesday soon. And if you have any ideas for future Wellness Wednesday topics and speakers, please email us at info@rolffoundation.org. On behalf of everyone here at Rolf Pancreatic Cancer Foundation, thank you for joining us this evening. We can't wait to continue celebrating with you throughout this exciting year. Until next time, stay healthy and take good care. Good night.